All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So as you can tell, we have the king of the rock stars. So Pierre, everybody says that, why are you guys rock stars? Why aren't you super doctors? So I think that this is our rock star band of the super doctors. Welcome. Thank you very much for being here. I'm very quickly going to introduce you, although I don't think you need any introductions. Cool Beans, here is drbeen.com. This is the Dr. Pierre Kory's CV. This is present. It is on his site, FLCCC.net or COVID-19 criticalcare.com. If you go over there and you go to the mission about and FLCCC physicians, you would see Dr. Paul Marek, another awesome physician, Dr. Pierre Kory, and others. Dr. Madhuri. So this is a neighborhood of high ambience. With this, here is the FLCCC's main site. You can, majority of you know what FLCCC stand for, what is their function, what is their role. In my opinion, at this time in the world, the contribution to promote a possibility of the management of COVID is done by this organization. While majority of the physicians and the healthcare organizations, they asked people to sit back at home and wait. And if they become blue in the face, go to a hospital. That is, while that was happening, this is the organization that came up and said, no, here is the pathology and here are the possible solutions, and please use them. And you've seen the great results of that. Here are the questions that we have for Pierre over here. Here is Pierre's Twitter profile. Please subscribe, enjoy. A few months ago, Pierre, I think you just started Twitter. I remember you had said, hey, I haven't been using Twitter, and here you are. And this is the YouTube channel for FLCCC weekly updates. And as you can see here, Pierre again and again with Dr. Paul Marek and others. So please enjoy very valuable discussions there. So once again, Pierre, welcome.
Oh, thanks. It's always good to be here with a friend and a colleague. And I wanted to tell you, have you heard about our new protocol that Paul and I wear the same matching shirt whenever we appear in public together? So
I saw that. That was so awesome.
That's our matching FLCCC matching shirt protocol. So we're
I
always
love that.
with new protocols.
I love that. So maybe what we should do that, we should follow that with you and me wearing Dr. Bean shirts every time we talk. How about that?
So let me tell the cool beans that I was telling King Bean that my Dr. Bean shirt happens to be one of those t-shirts where it just fits just great. And like, I always am drawn to it. So I wear it a lot. And it's a black shirt and I wear it in the summer. I don't care. I really like the shirt. So if anyone sees me out, and I'm never even out, but if you're lucky to catch me out, I'll be wearing a Dr. Bean shirt.
And I have a picture with Pierre in the Dr. Bean shirt. I'll share that again. So that's Pierre, if you can, so I see you do look a little tired. Tell me, how is your day-to-day look like nowadays?
So that's a problem. Lately well, here, let me answer it differently. So I've left 2 jobs in COVID because of differences in approaches to treatment. I just felt I couldn't remain employed as a full-time employee. There was just too many restrictions on my practice. But, for 4 months, from sort of January to almost May, I worked full-time for the FLCCC. They supported me with a stipend, and it was a really productive time, wrote papers and did a lot of research and, did all the stuff that we do in the FLCCC. But I really felt like I needed to get back to work. I started to feel like a fish out of water and kind of like a fake doctor. I mean, I was treating people, outpatient, friends, colleagues and all that, but that kind of slowed down, some long haulers here and there, but I don't know, everything derives from being there, with patients working. And so I went back to work in May. I really like where I'm working, but I work 27-hour shifts all in a row, and they're kind of rough when they stack up. So yeah, so in a week, I'll do 27 on like 7:30 a.m. till like 10:30 the next day, and then I come home, and then I usually have meetings for FLCCC, and then I go back to work the next day. And what you won't believe is I actually have a 2-hour commute to work, both there and back. So it's a little rough. So when I'm working, and I do about 1.5 weeks to 2 weeks a month of that work, and those stretches are just they're killing me. So anyway, I'm really busy clinically, but I like it. I really enjoyed being back, and if anything, sometimes it just kind of shuts the world out a little bit and allows me to just doctor. But then when I come out of the ICU, the asks and the advice and the guidance and the knowledge, I love sharing that stuff, but they're increasing. And so it is what it is, but I got to watch myself. I'm on vacation on Friday, going with the kids. We're going to Florida, actually. Nice hotel, and hopefully I'll get to rest.
Stay safe and stay blessed. Who can we reach out to complain to them about you, to say you need to take some rest?
They've already heard it. They're already in my ear. My parents are in my ear. My wife has given up years ago because she's used to me doing lots of stuff all the time and always overworked. I don't know if I'm a workaholic. I just get really interested in stuff, and I like doing stuff. So anyway, I wanted to make a mention. You showed our website and stuff. I got an email today. Check this out. I got an email today from our web master, who said that he ran a report on our website. And in the last month, get this, 605,000 new
attacks.
Visits.
Oh, wow. Really?
605. No, not attacks. 605. That's probably also happening, but 605,000 new visitors in 1 month. New visitors.
Wow.
Not old. Wow. We get a lot of repeats, but I thought that was truly remarkable. Maybe like Joe Rogan had something to do with that, and Brett Weinstein. But anyway,
so I'll tell you what is going on, and here is how I see it. I mentioned this to Cool Beans once before as well. In Pakistan, so India and Pakistan, when they were combined, Bangladesh, Indian subcontinent, at some point British came in and they said, "We're gonna rule you guys," and in that process, there was some not so good things that were done. And then there were some good people too. In Pakistan, there is a small town called Jacobabad. And Jacob is from Colonel Jacob. Okay. So he was one of the occupying people. However, he was so good. He was administering that town. And he was so good to the people. He was so helpful for them. His life was so meaningful for them that even till today, so Britain was kicked out in 1947. But even till today, that town's name is after that colonel's name. His grave is still, people go in the evening and put candles and lights and they light it up every day in memory of Colonel Jacob. What was going on was he was serving. He was helping, and his name is known even after his death in good way. So you are serving, you are helping. So folks who are coming in here, they are actually coming in for your service. They are coming in to get help, and with that is the recognition of your work as well. So that is what it is. I'm sure that Joe Rogan is there. I'm sure that Brett is there. I'm sure that others are there, but there is a fundamental seed of goodness in there which people are seeking. Yeah. And with this, I want to actually congratulate you as well for the Benevolence Award. How did that feel?
Oh, I have to tell you, it was so, I was pretty overwhelmed. I mean, it just, what you just said was really cool. I mean, I just appreciate the opportunity to be of service, right? To be helpful. It's a nice position to be in. We've just been trying to do good work, and I think we've done good work, and it's being appreciated. And so I like doing the good work and kicking out the, good information. I know we're helping a ton of people. We're not helping nearly as much as we want to. But it's been a struggle. You know this as much as anyone. I mean, we'll probably get into the dark stuff later, but like this insane censorship stuff, you've been a victim. I mean, there's been some crazy town stuff, and it's not getting any saner, right? But to get that award was just a really cool, just an interruption in day-to-day sort of ups and downs. It was just really cool to take a moment. I gave an acceptance speech, and I just kind of told our story, like where we started, where we've come from, and where we got to. And there was 5,000 people attended that lecture and that acceptance award all over Asia, mostly in Malaysia, but a lot of people listened to it. It was on the national news the next day, and it was just really cool. And the award, comes with $100,000 for us to do some charitable work. And I think we're going to try to help and guide some, treatment initiatives in Malaysia. And then some beautiful gifts, a nice certificate. And it was cool, and then plus it's like an East-West thing, right? So like now I have connections in Asia, and they were so appreciative. And here's the other cool thing, Dr. B, is that it was kind of the evening, and the lecture was sponsored by a group called the MAECC, which is the Malaysia Alliance for Effective COVID Control. And they are like the FLCCC. They had like a bunch of like really like-minded doctors, a whole bunch of docs, know the evidence, using it, and so like it's just so nice to have support and connections with groups that are, I don't want to say they're models of the FLCCC because they all grew organically, right? But I think we maybe have come out first, and they understood our science, understood the effectiveness of the drug, either personal experience, clinical experience, or just, understood it and believed it from the trials. And, there's a group in like every country, right? The Canadians have a group, right? We know the groups in France and South Africa and Zimbabwe, Indonesia, Sri Lanka, Malaysia. It's just, and a lot of Western Europe, Belgium, Netherlands. And so it's just kind of cool to have and then the UK, forget it, Tess Laurie and her work there. And you've probably interviewed or hung out with half of them, King Bean. So
absolutely,
you're
yes.
Right in the thick of it. So anyway, it was just cool to have a nice connection in the East over there. So hopefully we'll have some impact.
Absolutely. And again, we were talking about that before, and we have talked about you separately as well. You, FLCCC, your colleagues. It is not just this award. I actually believe that the impact at this time that FLCCC is making, the physicians that are making, Tess Laurie, Tina Pierce, Dr. Yo, yep. Bruce Patterson, Hector Carvalho, Eli Schwartz.
You remember, you're part of our most recent protocol. You helped spearhead that, and so we've done work together as well.
Yeah. I'm very, very humbled that I had that opportunity as well. I think these are the folks who looked at 7 billion people, and they said, we are going to go do something about it. How is it that we are doing? I think historians will tell, but here are the people, you are the people, the group who jumped up and said, we're going to go and help. So yeah. I think a Nobel Prize, I think a sponsorship for the FLCCC, these are the kind of supports that are needed to see when we can actually carve out a part of society to say this part is serving, then we should support that serving part as well. So once again, congratulations. And I think it is just a small token for all the work that you're doing.
Awesome. Well, thanks for that.
So for the Cool Beans, our discussion today will go over some of the questions that you have on Twitter, some of the questions that are here as well. But what I wanted to do was I wanted to connect Pierre as a person, Pierre, non-ivermectin guy, non-physician person, to us, the person Pierre. I wanted to know more about that. So because of this, you would not see me talking the mechanism of actions of ivermectin today, but majority. So my next question, Pierre, what is it that is making you happy nowadays? What makes you sad? What makes you angry? Again, within the COVID context.
Yeah. I mean, it's such a good question. You know why? It's because like literally in like an hour period, I can shift from one to the other. I mean, there are things that I'm overjoyed about. And then other things where it's just like, really, again, I mean, let's try to stay positive. But for me, I mean, for many months, like after we did our press conference and then after like the testimony went, Paul started giving lectures on ivermectin. Then we tried to bring it out to the public. We did a press conference in Houston. I don't know if people know about that, but that was the week before the testimony. And then we did the testimony kind of went viral. And then from then on, we got ivermectin to be talked about and looked at, right? We went to the NIH, and right around that time, to see these countries, and oftentimes, if not the national health ministry, but regional health ministries start to adopt ivermectin, and we would color in our little globe of like all the people who are adopting it. And it was just so cool to see, like almost like a wartime day. It's like you see countries fall like dominoes, right? Like we'd start to color them in, but it's a good thing, and that was what drove me for a while. And the problem is I was oftentimes in a really negative space because we got nowhere in the US, and in the beginning, it wasn't really censorship. Like back in December, when I say beginning, we're talking about like 8 months ago, right? Not 8 years ago.
Yeah.
But like that censorship thing came out of kind of nowhere. Well, we know it was going on and they're talking about it, but man, they started kicking it up a notch and another notch and another notch. And now there's like no end in sight. There's legislation going on. So the good stuff was that the word was getting out. The bad stuff was that like in North America and Western Europe, I mean, then the days like where just, so the days that you'd see countries and regions adopt ivermectin, those are good days. The days that a new report came out of the efficacy of ivermectin, those are good days, right? So whether it came from like a preprint or a new peer-reviewed article or a regional health ministry sharing their experience, I kept thinking like, here's more evidence. People are going to start to listen, right? And then the bad days were, and I'm sorry, but I'm just going to call it like I see it. I'm kind of done trying to be diplomatic, but one after another of a captured health agency coming out with some ridiculous statement like, there is no evidence for the efficacy of ivermectin. and it's so funny now. This is what's cool. Oh, this is a thought I had. Let me share you this thought. So I used to get so depressed and like angry and sad by like these attacks and these agencies, coming out with these ridiculous statements. That now I wouldn't say I'm enlightened, but it's gotten so absurd because the amount of evidence is so high, like literally the Mexico test and treat, the reports out of Argentina, India, doing what they did. And the amount of doctors who are saying this thing kicks butt. And then you contrast that with the way these agencies are still behaving. And it's reached a level of absurd. I almost can laugh now. I'm just like, whatever. These guys are so lost, so captured, that I can kind of laugh. But it does get me down. But you know the ups and downs, King B. You follow all of this.
I have not only gotten my things, my videos, my talks, my messages deleted, censored, blocked. On one day, I get a message saying, we reviewed your video personally, manually, and we find it all good. The next day I get the message that we reviewed the same video and we think that you violated a policy. I am not doing what
you're on a list somewhere. You're on a list somewhere, and so am I. Like the Dirty Dozen, man, they're after us.
I could not imagine.
And we're physicians, we're scientists. It's like we're just trying to help.
Yeah. to me, a person sent a message saying, because of my ivermectin discussions, he wrote a comment saying, I'm a software engineer and I know more medicine than you do because I talk about ivermectin.
Right.
And this is the sad part. So tell me this, in the middle of all of this, as much as you're working very hard, I am sure that with this negativity, with this pressure, I'm sure that you're getting threats of various kinds as well. How is your family coping with that? Work burden is something else. The social pressures that you're, how are they dealing with that?
I think they only hear the good stuff. They'll see like a mention of me, or someone says, hey, I saw your dad on something or another. So I think they're kind of proud that I'm out there. I got to tell you, that's a really weird question, because the other day, my 10-year-old, and I actually, you know what? I didn't follow up with her on this because we were doing something else. And she leans over to me and she goes, do people criticize you and don't like what you do? And like, I forgot to mention this because I didn't follow. I was like, I didn't understand the context or where that was from, but I thought it was a really interesting question because largely they just think that I'm successful in getting good knowledge, and they know I work with a group of experts. And, as you mentioned, I was already fairly well known as a physician before all this insanity started. I had I think a big impact on my field as one of the experts and pioneers in point of care ultrasound. And, my textbook is in its second edition, like 7 languages, and it's a really popular textbook. So I was pretty happy with the impacts I made before. And so they're used to, me doing a lot of work and being recognized for it. But yeah, she asked me the other day whether I was getting attacked or criticized. So, but I think largely they don't really know this. I shouldn't say that. My older one knows that I'm getting censored and stuff, but yeah, I don't know. My name's Poppy at home, right? I used to be Poppy Bean, and then I changed to Coffee Bean, but they know Poppy. Poppy's always working. That's what they say.
So it's a matter of pride. So the next question, you can see now various countries, as you said, falling in a good way to improving and protecting themselves. Which country do you think has done the best to protect their people in these non-CDC, FDA, WHO approved ways?
So at the country level, and here's where I'm going to have to walk that statement back, because we're going to talk about some recent data. So for me, what I've been saying for months is I thought Mexico's IMSS, right? Instituto Mexicali Seguro Social. So it's their social security system, but also controls healthcare, right? I think they involve or control something like 60% of the outpatient facilities. So their test and treat program, which they instituted December 29th, I thought that was the boldest and most organized move in the world. Okay, they increased their mobile testing stations. So like if you look at what they did in Mexico City, they increased the mobile testing stations to 250. And at all mobile testing stations, you got rapid tests. If you were positive, you got a treatment kit. Okay. And they not only did that, but they collected data, right? So they were a state system, so they could follow the data, and they put their preprint out. And what you saw happen after they deployed that, and by the way, and this is what we have to talk about in a second, that was not a unanimous decision. There was a lot of fighting going on. There's like little civil wars going on in these countries, right? So like the IMSS does one thing. I'm sorry, but the captured federal health ministry is holding up the WHO document and saying we don't agree. And like I have newspaper articles where they're literally fighting with each other. Like the journalist is like getting one to say one thing, the other one to say, like one saying, we followed the evidence, we used clinical experts, we used our best judgment, we used risk benefit analyses, and we deployed this program. It was not done loosely. And then, the federal health ministry saying there's no evidence for this, there's no evidence for this, the WHO doesn't recommend it. Like, crazy town on one side and really sound, public health officials on another. And they have this terrific success over months. They essentially open the country which was also happening at other time, like in the US also, we also had a decline as well. And then now, like, cases are spiking again, but they're arguing. Like, if you look at Zimbabwe, when they adopted it during their crisis in January, boom, you saw this plummet. They did great for a while. Now they're off the charts again. And I asked Jackie Stone, have you ever had Jackie Stone on your program?
Not yet, but we are reaching out to her.
Yeah, you should. She is phenomenal. I mean, she's about as experienced at treating COVID and using ivermectin. And she has used ivermectin in some of the sickest non-hospitalized patients. She has like this little clinic where they're like coming in with SATs of 55, and she's essentially nursing them back to health with ivermectin. And but I was asking her, I said, what's going on in Zimbabwe? I thought like it was settled science. I thought like everybody's using ivermectin, because at one point she joked with me in March. She's like, we're ready for the next pandemic. You got another one. It's boring around here. Right. And so little cocky, because now it's going nuts. And I asked her what's going on. And it's the same thing that you're hearing from a lot of places, is there's still doctors who've taken that stand. There's still parts of the ministry, they don't believe it works, and they fight against it, or there's more nefarious forces. So it's not like everyone's like in lockstep, arm in arm, saying, hey, ivermectin is a key outpatient therapy. It's still, and supplies are sometimes limited, and it's. So, and I think your question was, where do I look to the most? I think Mexico's example is great. Same thing's happening in Mexico. But there again, IMSS is bringing it under control again. So anyway, that's my long answer to say it's still going to remain controversial. As long as these public health agencies, the big guys, as long as they keep putting out really bad guidance and advice around ivermectin, you're going to still see this horrific resistance and fragmented use.
So 2 important questions. Number 1, if today we said to you that you have the support to implement your rules, your policies, your regulations, your approach, can you end the pandemic in that next 1 or 2 months? What will you do?
So I believe you could, because here's what I would do is, number 1, I would do what Bulgaria did. So I'm going to borrow different moves by different ministries and countries around the world. So number 1, I would borrow Bulgaria's approach. Make it over the counter. Over the counter. Remove the doctors, okay? and it's a sad thing to say, because, yes, you do want physicians' advice and all that. But at the same time, the reason why I'm saying make it over the counter is because that's what's so cool about ivermectin, right? You and I both know a lot of drugs work in this disease, right? When you look at all the trials, and some are small, some are big, but ivermectin stands out because it literally has decades of safety data. It has decades of use as a public health initiative, where it's literally distributed across continents to children, to, women, childbearing age, pregnancy, older. And so, like, you have this history of a drug which tells you that you can literally just give it out, right? Obviously you want some guidance around it. So 1 is over the counter. 2 is, I would love if everyone did a test and treat, but that's a little bit of a wish list in the US. But once you made it over the counter and you gave good guidance, so pharmacists, or with that over the counter bottle, you would have an insert to say how you would use it in COVID. And then I would follow our protocol. So for high-risk individuals who are not vaccinated, take ivermectin weekly, period. This is the dose. For household members who have someone who caught COVID, take 2 doses, like we spell out, right? And that would tamp down transmission to a huge degree, right? And then remember that the one part of that my main problem with this vaccination policy is that it's obsessive and monolithic. Like, we know we need a multi-pronged approach. There's too much vaccine hesitancy for myriad reasons, right? It's not all ignorant people who are like, I don't know, they're always caricatured as these like Republican ignoramuses, right? That's not true. It's a very heterogeneous group of people who are resistant to getting vaccines, but you got to accept that reality, right? So you're going to need complementary and multi-pronged approaches. And so ivermectin would be a perfect complement. So over the counter, in every cupboard. So if someone falls ill, the family can prophylax. You can start treatment early. And if you start treatment upon first symptoms, you literally will avoid hospitalization in the vast majority. And literally the transmission rates would be extinguished. And they would be complementary to other policies. And I think you'd see such low incidence rates that you'd see stuff open up. Tell me when I'm getting too fantastical here, because
please do. I wanna hear this, because I believe this can be done, and I believe that the world can be saved from this misery and brought out of it very quickly. This is why I asked this question.
Look at Uttar Pradesh, right? They, from like August, so remember, 234 million people. And I know the physician who spearheaded their public health policy, which centered around ivermectin as an early treatment. They adopted this in August 2020. So although I gave credit to Mexico, maybe let's go to Uttar Pradesh for a second, right? So one of the most populous states in India, 234 million people. I think it would be like the 8th or 9th biggest country if it was a country. It's only a state in India, right? They adopted for early treatment back in August. And if you look at their numbers was, oh, wow, I got into, is that Dr. Yo who asked that question? Are you kidding me? Is he interrupting with those questions? Or is that someone impersonating him?
It is Dr. Yo. Dr. Yo.
Okay.
So the unwritten rule or process between Dr. Yo and I is that whenever we have an awesome guest, Dr. Yo trolls them in an awesome way as well.
Well, he trolled my thoughts away, but that's a good one. Ivermectin thong. So, is in our donate button on our website, there's a store with merchandise. And at first we really didn't like it. And I know Paul didn't like it. He just didn't want merchandise, but we told him it's a common way to, raise money and whatnot. And so, but there's a pair of tights on there, which are, they're really interesting. But anyway, yeah, we don't have thongs, but we have tights. But if you look at Uttar Pradesh, right, they did so well, like such low case counts, such low deaths for a long time. And then in that Delta wave, right, in April and May in India that washed over India, that, where it's like literally a humanitarian crisis, they got hit hard because of millions of migrant workers who were fleeing Mumbai, right, because they didn't want to get locked down and have no money or food and couldn't work. So they went back to Uttar Pradesh. And so you had this huge influx with this massive spike of infections. But Uttar Pradesh went to train stations and railroad and bus stations and airports, and they started testing everybody, and they were providing early treatment. They brought it down. And if you look at the numbers in Uttar Pradesh right now, it's like literally almost none. I mean, no cases and no deaths. And so they've also shown a really robust, very organized, what a robust, organized approach centered around early treatment with ivermectin can do. And so, yeah, I mean,
got it.
Yeah.
So next question then. If you were running, I know these are fantastical questions, but I want to be able to put in front of the cool beans that if a physician and a leader is thinking about the management of COVID versus a captured party thinking about it, what is a contrast in thinking? So if you were running NIH today, what will be, so now your tools are, let's say, vaccines are a tool, masks are there, drugs like ivermectin are there. What would you do as a whole for the country and then set an example for the world?
Well, the first thing is, although this government, so if we talk about the U.S., so just talk about the U.S., I guess. So the U.S. has just been, like I said, has had an obsessive and singular focus on vaccines. And if the vaccines could end the pandemic, great job. That would be if they were proven short-term, long-term safety and proven short and long-term efficacy, that would be the way to do it. And everybody could take one or want to take one, that would be great. We know from our history of flu vaccinations that even with the best of messaging, you can't even get people to take flu as much as they need to. So that obsessive focus is devoid of an early treatment option, right? Because here's a couple of things. we know that not everybody is going to get vaccinated. And I just have to call out one thing that really angers me is the demonization of these people that you're seeing in the media. And I mean, these are my patients. It's like, I'm a lung doctor, right? So I've been taking care of smokers for decades. I don't demonize them, right? Even though they might do something that endangers their health. All of us have patients that don't make the best of decisions. Now, the decision to get vaccinated, I don't want to get too much into vaccines. Again, it's for every patient, it's a little bit different, right? And so I don't like that they're demonized, because here's the other reason why I don't like demonizing them is we need an early treatment option. That we have no policy for early treatment. And just like you mentioned in the beginning, we can't even get our government to recommend vitamin D. They can't even recommend vitamin D to the population, a population that they've studied for decades. The FDA has data knowing that large proportions, oftentimes in minority communities in the North, nursing home residents are all vitamin D deficient. And they can't even come up with some sort of recommendation for vitamin D. I mean, like I said, I keep using the word absurd. So there's no early treatment option. So when you said, like, what would I do as the NIH? So the first thing is I would employ an early treatment option. And keep in mind, ivermectin is only one of the things that works, right? We know of a number of other agents. We're impressed with the pathophysiology and mechanisms of fluvoxamine and the efficacy of fluvoxamine, right? And then there's povidone iodine. That's on our protocol. Like, what's wrong with a little bit of oropharyngeal, nasopharyngeal decontamination with an antivirus, an antivirus thing, right? It reduces the viral burden. It probably reduces propagation. And in the handful of trials that you're seeing now, they're pretty effective, right? So, I mean, there's some simple things you could do to the population. So, number one, I would just use like sound reasoning, which is like, be pragmatic, be commonsensical, safe, widely available, cheap, likely highly effective therapies. Please tell the population, protect yourself with these interventions, right? Once you had that early treatment piece, I don't even know what the other stuff that you would have to do. I would like to reassess after a massive early, that void that we have. Remember, my testimony in Senate was literally about that void. Like, what are we doing for these patients before they get to the hospital? And so once we put that building block in, alongside the vaccines, I think you'll have the triple threat, right? Right now, what do we have? And we have big time herd immunity, which from the evidence, right? If you've had COVID before, there seems to be long lasting, very durable immunity. So you have the herd that's already gotten COVID. Then you have the people who are vaccinated, and then put in ivermectin, both as a preventive and early treatment.
And you also have patients who recovered asymptomatically. And you also have a group of children who are not that high at risk. So that really provides a great protective shield. Yep. So tell me this, before I ask you some questions, and I know that
last thing I want to mention about that is that, and this isn't part of the policy, but going back to the demonization of the unvaccinated, is that I think a really cool way that hopefully people will listen to us more is that we are getting reports of a fair amount of breakthrough infections, right? So there's no hard numbers. The US, for some reason, you can't get good numbers. But when you're looking at some of the other countries that are sharing their numbers, like, you're seeing a fair amount of breakthrough infections. Here's my message. Fully vaccinated people will need treatment. Stop blocking early treatment, right? Because if you want to demonize the unvaccinated, like, oh, you got sick, we're going to blame you, tough on you, I don't think they're going to have that same attitude when the vaccinated people get sick. So if I can prey upon them to listen to us, to offer some treatment for those worthy, you get what I'm saying, being cynical, those worthy, those who decided to get vaccinated, hopefully that would fall upon some open ears, right? Some of the anti-IVMers who got vaccinated, well, God forbid they get sick. I'm here to help.
Absolutely. And then on top of all of this, the potential reduction of long COVID, both with the infection and the vaccine.
Oh my gosh. I mean, I tell that to people, I've had a couple of people recently who were mild. Like, one was the wife of someone I met. He was sick. He agreed to treatment. And the wife kind of didn't want anything. She didn't want to be treated. And she was kind of mild. And I said, you know, I don't want to force anything on you, but the best available data we have shows that if you get treated early, you don't get long COVID. And your risks of long COVID probably are near nil. And so I said, although you might not feel sick enough where you want treatment, as you and I both know, long COVID is just devastating, right? You want to avoid that at all costs. And so another reason to get early treatment out there.
So I want to ask you one more question before I want to do some rapid questions with you as well. So
Sure.
one question, the I Recover protocol, I participated in that as well.
Yeah.
How is the feedback so far?
I mean, we get testimonials all the time. I mean, they're just, we had them even before just on ivermectin, and we get testimonials all the time. You know, I was talking to a very well-known physician who was a long hauler himself, and learned about ivermectin after my testimony. And he's treating himself as long as many of his patients in his practice. And he reports excellent efficacy with one caveat. And this is the vexing part of long haul. I'm going to give you a short answer so we can get through a few. But King Bean, these long haulers, many of them have to stay on ivermectin. Even my colleague, I mean, he's been at it 8 months now. He has to take it 2 to 3 times a week. As soon as he stops, the symptoms come back. And so, I mean, it's a good message and a bad message, meaning that we can help you, but it requires maintenance therapy. Right?
Agreed. Yep. So as I promised in the beginning, who is Pierre, connection to the people. So some questions that are my own curiosity as well. Sometimes I think about you and Paul Maddock and others. So coffee or tea?
Oh, coffee. Come on, I'm Coffee Bean.
Yes,
I don't even look at tea. Oh my God.
So no tea.
Never.
How about plane, train, or car?
You know what's funny is I never used to like cars. I was a train guy. I lived in New York. I commuted. So I love trains. I did all my work on trains. So yeah, I like trains. I definitely like trains. But the funny part is I have a Tesla because now I commute. So I like that autopilot thing, and I love that Tesla. I never used to be into cars, but now that I own a Tesla, it's, oh my God, I can't stop talking about it.
I love it. I love my dream is Tesla. So at some point, I'm going to get Tesla as well. Which weather? Winter, summer, both?
You know, I used to love winter. I love the fall and winter. I love cold weather. Now that I live in Wisconsin, I like summers. The winters are long here and they're annoying.
So don't be offended. This question is important. Would you like a hairbrush or a comb?
Right here. This is what I use every day. This is all I need. And it's been like this for like 2 decades. So I get just fine with my hands. So that's all I did. Look, see, boom. Perfect.
Done. Very good. So let's ask some questions.
Hey, wait, you want to know some fun facts about me?
Yes, please.
If the cool beans, I'm going to freak them out here. So maybe this isn't something I should be proud of, but I've made a comeback. I kind of failed out of college. Or not really failed out, but like I'd lost my way, and I left with like a few credits left. I did not get good grades at the end. I lost my way in my early 20s, and actually I was in the restaurant business all of my 20s. I went to medical school at 29 years old.
Oh,
29.
Really?
Yeah, and all my years in the restaurant business, I put myself through grad school. I started doing research while waiting tables and running a restaurant. And I did that till I was 29. And the funny thing is if you look at the FLCCC, all the guys with me, decades of practice. You know how long I've been since out of training? Like 12 years. 12 years, 13 years.
Oh, man, yeah. You are young.
Out of fellowship. So I'm a baby. Yeah. Oh, I'm a baby compared to all you big guys, all you great people.
Oh, wow. And look at the impact that you have.
Yeah.
Beautiful.
In a run.
So tell me this then. You are our hero. Who is your hero?
Paul. Paul Marek. He's a beast. I love that guy. He's phenomenal.
He is awesome.
I love arguing with him. I love listening to him. You know, I'm going to give a fun fact about Paul. And this, I found his secret, why he's so smart and why he's such a good doctor. He told me just recently, I hope he doesn't mind that I share this, but he told me that when he's stressed or doesn't have a good day, you know what he does to relax? He reads medical papers.
Somehow I knew that is what he will be doing.
And when I heard that, I'm like, that's it. That's your secret. He literally, it calms him and he feels better when he reads a medical paper. And he's like one of the most well-read guys. And he's sensible and smart and just, he's great, you know, and he loves protocols. And that's, you know, he's the blueprint of the FLCCC. So,
makes sense.
Yeah.
So then one more question. You have tremendous leadership capabilities, skills as well. Was that all along as you were growing up, or you actually cultivated and focused and learned this skill?
Well, I'll say I probably noticed that after college, and this is not an ego thing, but I noticed that wherever I went, and it also could be like a loud white male syndrome. Like, I'm from New York. I think I'm reasonably intelligent. I'm not afraid to share my thoughts. And so, like, you know, that kind of white male thing gets celebrated in society. So I don't want to say like I'm better or smarter than anyone. You get certain advantages as a loud, white, smart male, right? And so, but I'll tell you this, everywhere I went, I tend to get promoted rather quickly. And I just sort of, you know, even in the restaurant, I rapidly became like, you know, a head waiter, a manager. When I was in fellowship, I was like the chief fellow. And then I was like one of the youngest program directors. You know, I used to be a fellowship program director. And then I went to University of Wisconsin, and, you know, at 7 years out of training, I was the chief of the critical care service. And I was the director of a Big 10 major ICU 7 years out of training. And so, I don't know, I just always kind of, I don't know, just, yeah, I guess, I don't know, people have looked to me for, I don't like leading, actually, to be honest. At least in bureaucratic organizations, I'm like not cut out for it. In fact, I was always just, there's lots of friction and so many rules, and I'm kind of like more loose about stuff. And I don't know. Yeah, I don't do well inside institutions.
Got it. Thank you. So there's a question. Casey Smith says, Dr. Kory, how do you plan to protect your children in the upcoming school year? Mask mandates have been removed where we are, and the virus is running rampant with school starting soon.
Yeah. So, okay. So one of my children got COVID. So she's protected. Another one actually can't get the vaccine. And with her, we're just going to do an early treatment approach. You know, we have it on hand in the cupboard if she ever gets sick. We would just treat her immediately. And then my other child, who's 16, she actually prophylaxis was with ivermectin like I do. And so,
and is this recent?
What's recent?
This COVID that your children got?
So my youngest got it like 6 weeks ago.
And you are okay. You didn't get it. You are. Of course.
I've never gotten COVID. No, I take ivermectin every week. I've taken that since early November.
It will be so interesting to see your antibodies.
You know, it would be. If I had time, maybe I would check. But I'll tell you, one person close to the FLCCC, he's the father of the family. He takes ivermectin like I do every week. His wife doesn't. She got COVID. The kids got COVID. He didn't. And so, wow. You know, again, it's just an N of 4, but just interesting that in a family where one prophylaxed and the other didn't, he didn't get COVID. So,
and so your family is fine now, right?
Yeah, my wife got vaccinated early on in the first wave. You know, when they were first going after healthcare workers back in like February. One kid got COVID, the other one prophylaxis, and then the third we're just going to treat early if she were to get it.
Got it. Thank you very much. So I'm going to ask you some cool bean questions now. So Dr. Sammy is saying, is there a dose response curve chart for ivermectin?
So chart, I haven't seen a chart, but the way Andy Hill did it in his most recent article in Open Form Infectious Disease, basically he split it up into like single day dosing, multi-day dosing, and then I think there were actually, no, what he did, I think he did total dose. and I don't think I didn't see a chart with it, but there was enough data there where he concluded that there was a dose-response relationship, statistically significant. Again, he could only use the trials that actually, and the outcome was viral clearance by PCR. So his time to negative PCR was shorter in the higher dose. It was longer in the lower doses and shorter in the higher doses. Hey, it's Paul Marek. Should we say hello?
Is he here? Yeah, absolutely.
Hey, Paul, guess what I'm doing? I am on the phone with Dr. Bean. You're on speaker. We're talking to him in the Cool Bean. Say hello.
Hey, Paul.
Is this a live thing?
It's live. You're calling in on a live program, sir.
Okay. So maybe you or him can answer the question.
Okay. Why don't you tell it? Paul has a question, King Bean.
Okay.
Go ahead.
So assuming spike protein following vaccination circulates by the body and then gets taken up by the endothelial cell, can the endothelial cell express the spike protein on the membrane the same way as SARS-CoV-2 does? Because that's what people are saying, and I think that's complete nonsense. Because you need complex viral proteins to transport the protein to the cell membrane.
Yeah, I mean, an endothelial cell is not a virus.
Exactly.
Yeah.
Yeah, and it will not. Because the other way will be if spike protein binds to ACE2, ACE2 has no mechanism to bring it in and then express it again. Neither is there a mechanism of endothelial cell to pick up a spike protein and then re-express that.
Right.
So it's not going to do it.
All right, we're all in agreement, Paul.
Yeah, because that there's this guy that's saying that that endothelial cells start expressing spike protein, and that then triggers clotting because of platelets and all kinds of stuff.
Yeah, I don't think he's got the mechanism right.
Yeah, so I think that's BS.
Me too.
The only way with a spike protein we could cause endothelial cell to become abnormally functioning is, and it cannot happen in vivo. If in vitro you take an endothelial cell, you put a spike protein on it, that occupies ACE2, that creates an imbalance of ACE1 and ACE2 function, which causes pro-inflammatory side to become prominent. But that cannot happen in vivo because spike protein cannot stay on the ACE2 for long, plus the ACE2s are recycled all the time.
Yeah, so I think if spike protein gets into the cell, it can then activate a whole host of cellular pathways via toll receptors and whatever. So it can activate inflammatory pathways, it can activate complement, but it can't activate pathways that cause it to express itself on the cell membrane as if it was a virus.
It's impossible.
Agreed.
Yes, it's impossible. Okay.
All right.
Because there's this ridiculous thing going around, which is clearly not correct.
Agreed. Agreed.
Okay.
All right.
Even if this spike protein was picked up by, let's say, macrophages or monocyte, the antigen presenting cells, even then it will not express on the surface as it is. It could be broken down and pieces will be expressed.
Yes, I mean, so you could ask RAM and the monocytes. I mean, the spike protein is found within the monocyte. It's not expressed on the surface of the monocyte.
Correct.
Right. Correct. So,
Okay.
yeah. Okay, Paul.
Did you ever get hold of RAM?
Yeah, well, Ram is trolling us on this. He put in some message. Hey, Ram, if you're listening, you didn't answer my text. Paul and I want to have a Zoom with you later. Maybe we could do this offline, Dr. Bean.
Yeah, Ram was in
Paul,
OR.
we're doing like a show here, man. Get out of here. Bye.
All right. Good job.
Welcome to the FLCCC. You guys are really getting an inside look today, King Bean.
We actually planned a behind the scene action for the team here.
Yes.
Okay, so I know that you have another 10-15 minutes. I'm going to go over some of these questions. So Avox, Mocha Bean, he's the one who donated the coffee bean title back to you. Dear lovable Dr. Kory, We know zinc in cells inhibits coronavirus replication. We know zinc ionophore increases zinc in cell, but studies conclude zinc plus zinc ionophore prophylaxis had no effect on COVID. Obtusely didn't then ask how come. Is that normal in medical studies? It scares me.
So I haven't followed the most recent. I haven't seen those studies he's referring to, but the one thing I would say is looking at one molecule alone will oftentimes lead you to, I think, inaccurate conclusions. I mean, everything is oftentimes synergistic and complementary. All of our protocols are combination therapy protocols, and so to test them as an individual element is not correct. But I also have to beg ignorance. I don't really know exactly what studies he's referring to.
Got it. Fair enough. Colina says, is the data coming from Israel on how long the vaccine is effective?
Yeah. So again, I want to be measured in how I answer. I mean, the data from Israel is concerning, right? Because they're saying that people are getting COVID, and even those in the hospital. Vaccinated people are still getting COVID. The overall numbers, absolute numbers in Israel is not high, right? So, I mean, there's definitely significant amounts of breakthrough. They're much higher in the UK. Here's what I say about all of it. I'm just going to summarize and give general statements. It is my belief that we don't have enough data. We don't have enough short-term or long-term data on the efficacy and safety of the vaccines. That is an evolving situation. I don't believe it's a settled science. I know that people are adamant that it is the cure for the pandemic. There's a lot of pro-vaccinators. There are a lot of hesitant vaccinators. I hate the term anti-vax because it lumps everyone who has a concern about the vaccine in one camp. And there's a lot of really smart scientists who study the immunology, have questions on it. And so I just hate that it seems so settled when it's not. I mean, you can see the data is evolving every day. We're learning new and different things about the variants and different vaccines. And I just think that we need more data. It shouldn't be a controversial position, really. So
Makes
that's
sense.
what I would say.
So do we know how long natural infection immunity lasts?
Well, there's been a couple of recent studies, right? There's the VA study of healthcare workers. There's Cleveland Clinic. I think over the past, that Cleveland Clinic study showed in maybe 1,500 with prior COVID, and there's almost no infections. And that was over a year plus period. So again, that's another question. We need more data. And I think more data will come out. I mean, we can follow healthcare workers. We can follow others. Probably healthcare workers are the best, right? Because, they're kind of easy to get to and study. And I think there's longitudinal studies going on, but it seems to hold up very well.
Yeah. Agreed.
Which is a really great message. It's a great finding, right?
Agreed. And if we look at previous infections with SARS-CoV-1, not 2, the antibody protection continued for 2 years and then declined in the third year. And T-cell protection continued for 10 years.
Huh.
So that is one. So, of course, there is a difference with 2, but still, there is some extrapolation that can be done.
Oh, I agree.
Wicked Lasers say, your protocol recommends taking weekly ivermectin for prevention. What is the end game, as surely one would not want to take ivermectin for the rest of their lives?
Yeah, that's a cool question. So I have a few ways to answer that. So number one is going back to your awesome questions about me pretending I was the head of the NIH and what I would do. But if you can envision where we have an R naught that's so low and such a low case incidence where it's rare to see it, you could stop taking your ivermectin, right? So I can envision a time where we're out of this hell and you don't have to take it for the rest of your life. So that would be one way to answer it. Another is people take aspirin every day, statins every day, beta blockers, ACE inhibitors. I mean, I'm an internist, right? A pulmonologist. My patients who have chronic illnesses, they take medicines every day for the rest of their lives. Now, I could see where a healthy person wouldn't want to be relied on a medicine, but what's lucky is that it seems to be very safe. And so it wouldn't be the worst of scenarios if you had to do that, but I envision a time when once the public health systems realize that we need complementary and a multi-pronged approach, I think we can get the case rates and incidents down to you don't have to take it forever. So just hold on until the miracle happens.
Makes sense. And there could even be selectivity that, for example, if you're exposed to someone who is coughing and sneezing and you don't know if it is COVID or not, maybe take ivermectin then. Or if you're traveling, maybe take it then. So there could be some thinking that way as well.
And that's true. You know, just looking at that question, we recommend taking weekly ivermectin for high-risk individuals. And that's in a little bit the eye of the beholder. We leave it, you know, we know what the risk factors are, right? It's older, comorbidities, diabetes, that obesity, that kind of thing. But yeah, you could just do an early treatment protocol. Just keep it on hand and take it as soon as you get a symptom.
Got it. Colina says, should an 82-year-old be taking ivermectin prevention long-term? Similar question. My
parents do. And they got the J&J vaccine, but they take ivermectin every week. And there is no risk to the liver. There's literally 3 cases of hepatitis in the literature. 3 cases resolved. So, and also the insert says you don't have to do adjustments even in liver disease. So, you know, this liver thing with ivermectin is really, it's a shame. But there's no risk to the liver. No appreciable risk.
Got it. Thank you. Andre de Bale says, what kind of efficacy and which symptoms seen to respond to ivermectin in the realm of vaccine injury? How about numb lower legs, difficulty walking as treatable post-vaccine without IVM?
So I haven't treated that form of post-vaccine, but I've treated a lot of more of the inflammatory ones like myalgias, arthralgias, fatigue, headaches. Those disappear on ivermectin. I just was in an international Tess Laurie put together this cool Zoom this week, probably maybe 40 or 50 of us from all around the world, part of the BIRD consortium and otherwise. And we talked about long haul and post-COVID and hearing the experiences of others. And there was one physician who had a really dramatic clinical anecdote of someone with a really bad neuropathy. I think they were insensate on one side or another, or they had some really terrible neurologic symptoms, which absolutely resolved with ivermectin. But that's just a clinical anecdote. So I offer that as a possibility.
Got it. Thank you. R4G3Y says, any studies on people died of COVID during sleep, whether they have history of breath through mouth or nose? Does H2O2 hydrogen peroxide help reduce COVID in mouth and lungs?
I don't have experience with either. So yeah, I don't know how to answer one. I don't have any data on that. And I don't know, I've heard of a lot of, I've heard of clinicians who really believe hydrogen peroxide is effective. I'm going to just profess ignorance on it.
Got it. Matt Force says, some using prophylaxis ivermectin will be forced to get the vax. If so, which one? J&J and one shot is appealing. Okay to stay on ivermectin during vax process.
Yeah, I'm going to pass on one. On two, we've asked some vaccine experts, and they don't believe that there is an issue, that it wouldn't be a problem to get a vax on ivermectin. But we sort of just maybe for caution, we just say stop it a week before. We just don't have data on that, to be honest. But we just think it's reasonable to stop. You know, take your last dose a week before the vaccine.
Got it. Thank you.
If you're going to get vaccinated, yeah.
Matthias Zakari says, what helps you to keep your optimism and inner strength? Thank you so much for your work. It gives me hope to know that there are good doctors like you and your colleagues.
It's days like today where I get to talk to like-minded folk. You know what I'm going to tell you? That's an easy answer, because it's literally, I almost have to be in a cocoon of I wouldn't want to say that we're groupthink or anything, because we really do critically analyze data. But, you know, I just like the network of clinicians, physicians, researchers, citizens around the country and world that reach out and share experiences. And, you know, I mean, I get a lot of attacks, a lot of stupid stuff, a lot of disappointments with the responses around early treatment or the failures of early treatment policies. But there's also a lot of successes. I am not like I'm not a sunny guy. Oftentimes, I can, you know, I'm like angry and I can bitch as much as anyone else. But I don't know. I'm friendly. I like talking to people, and I'm meeting nice people, so they keep me happy.
Got it. Thank you. Buzz Night Gear says, is ivermectin okay to give to a 7-year-old girl who is heavily disabled with neurological problems?
So, I mean, I got to be careful. I don't want to give medical advice necessarily, especially not at the patient level. So I can only speak in generalities. But ivermectin has been given, again, 4 billion doses over decades across continents, and has been given to children. It's been given even to pregnant women, elderly. It's literally one of the safest medicines. So, there would be no hesitancy to anyone, no matter what comorbidities they had. There's really no hesitancy. The only thing you would look for is for drug interactions, and there are very few that you have to be concerned around, right? I'm sure you've covered this, but it's like warfarin, some of the transplant drugs, and then others have interactions where it might raise or lower the level, but that's usually not a problem.
Agreed. Chip says, is apnea a comorbidity? I'm assuming for COVID.
Oh, like sleep apnea.
Yeah.
I would say if it's associated with obesity, and obesity is the most common cause of sleep apnea, then it would be the obesity that's the risk factor. I don't have data. So there are people, right? You know this, King Bean, is that there are people with sleep apnea who are not overweight, right? So those people I would not consider sleep apnea. That's just like kind of abnormal anatomy type thing. I don't think that's a real risk factor if you're not obese. Totally
makes sense. Dr. Amir Hashmi says, can we use azithromycin or doxycycline in early COVID?
We're underwhelmed with the data. We don't have it in our protocols, but many people do. They think there's a synergy or efficacy. And so, all I can answer is we don't have it in our protocols, but other really smart doctors do. Jackie Stone, that is the mainstay, her and Barodi, they all use, I think it's Zithro with ivermectin in their early protocols.
Yeah, and I believe that the original Cali study, if I'm recalling it correctly, in their in vitro study, they had also used azithromycin as a test as well to see it potentiates the effect of ivermectin. How exactly is not shown.
Right.
RC Stout says, how can I get a script for ivermectin if PCP won't prescribe?
Most common question in the world, or at least in the US, actually in the world. Our answer is you can go to our website. Right in the center in quick links, there's a button that says how to get ivermectin. Oh yeah, look at you bringing it up. So get ivermectin right down there in the middle of the quick links, like go down a little bit. Yeah, there you go. And here's the thing, please read the disclaimer, because we don't control or curate or validate the list or verify, the quality of the service delivered, but it's just a list of practitioners, telehealth. Many of them are multi-state, so they cover most of the states in the country. And they'll do a telehealth visit, and they prescribe for prophylaxis treatment and whatnot. So I don't know. I just point you to that website, and people find it very helpful. They've been very happy with their ability to find physicians who use it.
Right.
Yeah.
Thank you.
And no conflicts of interest. They don't pay us. It's just kind of like a service because everybody asks us the same.
Makes sense. Rachel Harbin says, can you use ivermectin liquid from store?
Okay, so disclaimer, I cannot recommend animal ivermectin, but I can talk about animal ivermectin. So a couple of things. Ivermectin is ivermectin. Human and animal, especially if you're dealing with tablets, the difference is that one has a regulated amount of impurity, and if it's FDA regulated, it's got very, very low impurities in the tablet. Animal ivermectin is not as well regulated. Now, we don't have safety data for the animal form, the pill forms of ivermectin, so we can't recommend it. We also really don't have the toxicity data either. I mean, we know that people around the world have been using that stuff, but we can't officially recommend it. When you go to the injectable liquid forms, what I've been made to understand is that is pure ivermectin with like glycerol, which is a very common diluent additive to lots of different medicines. But so that form, I'm just told that's pure ivermectin with glycerol. And again, that's all I can say about it.
Got it. Thank you. Thiral Burned says, are there plans to expand the FLCCC network of physicians in Europe urgently needed everywhere?
Yeah, so we do partner with and talk to groups that are similar to the FLCCC. We haven't figured out how to like have chapter, like we're still a small band and we're growing, but what we do have is on our website we have what we call it's the Alliance. So physicians the world over can sign up, and we have a pretty large group that have signed up as part of the Alliance. And so when we have things to share with them, our webinars, we're talking about a newsletter. I mean, certainly anyone can join the Alliance, but to have another FLCCC in another country, we did have some people requesting that in some of the Asian countries. They wanted to start a chapter there, and maybe we'll come up with a system for that, but we haven't really done that quite yet. But you can always join the Alliance right there under network and support.
Got it. And you have a censored video here.
Now it can't be. That's our website. That's a mistake. I got to find out. I got to tell the team that there's a video that's missing. All right. I'll tell them to put that back on. Yeah, and this is where, these, if you go down, that's just a lot of the core physicians, and then we have a lot of global health partners, some very prominent physicians, and then a list of others. But at the top, it says join. When you go to that link, network and support at the top, you go down to join the FLCCC Alliance. We also have a nurses for FLCCC, and so we encourage nurses to join. So we're just trying to build a network of folks who support our efforts.
Makes sense. Makes sense. Thank you. Casey Smith says, will there be a suggested prophylactic dosage for teens avoiding the vaccine? Children too, mask mandates have been dropped in school. And second is, as the data continues to show the vaccine losing its efficacy, do you suggest prophylaxis with vaccine dosing with vaccine?
So for number one, we have not really recommended young folks to we haven't recommended that they prophylax because they really do weather this well. But I would say for children, it's probably best suited just to have an early treatment, right? It's just keep it and treat very early. I think they're going to do just fine. Most of them do it very well. That's even without treatment. So doing an early treatment for, someone under 18 is reasonable. If you want to be more risk conscious or you are concerned about maybe, there have been some unfortunate severe illnesses in kids, but I will argue they haven't been treated. I haven't heard of ivermectin failure in a kid. Maybe you want to prophylax, but we don't recommend prophylaxing children. Number two, yes. Yeah. I mean, as like I said, the data is evolving, and if you're starting to see data where efficacy is waning, and there's a lot of breakthroughs depending on which vaccine or not, why not? This is a multi-pronged approach. So, we've used that phrase that we consider ivermectin is a bridge to vaccination for those areas, who don't have it yet. I think would be a bridge to it. And it's also a safety net for vaccination. And that's the other way in which we think it could be used, is that if the vaccines are losing efficacy, you could support yourself with ivermectin.
Got it. I'm going to just very quickly, Art Patron Forever, he's a cool bean, says, or she, there are a bunch of blacked out videos on FLCCC site.
That's a really weird discovery to discover right now. I'm going to tell the team immediately that they need to look into this. I'll let the team know right now to fix it.
Thank you. Eileen Glazer says, Dr. Bean, please ask about purity of ivermectin from India. I guess the question is...
wait, what is the question? What is the purity of ivermectin from India?
Is the ivermectin coming from India okay to use? I think I'm paraphrasing.
I get my ivermectin from a Canadian pharmacy that sources it from India, and that's what I use. I haven't had it independently tested. I have not heard complaints. I haven't heard of any failures. Seems to work. But again, I can't really answer that question. I don't have that kind of.
There is actually no way to guarantee. Austin says, why do you think vaccination mandates are happening when breakthrough cases are going up?
So what's the question again?
Why are vaccine mandates are happening even when it is when there are
Hey,
breakthroughs.
Austin, are you literally asking me to explain public health policy? He's literally asking me to explain public health policy.
Yeah.
I mean, I would listen. That is not a question I can answer. I have the same question. You know, I have the same question.
Makes sense.
I don't know. I don't know the answer to that.
So some more questions here. We're almost there. So Mirror's Edge says, there's a Vicky's question, your opinion on pros and cons of monoclonal antibody infusions, for example, Regeneron, which is actually a polyclonal, in addition to immediate IMAS plus for COVID-infected 60-plus-year-olds. When should it be administered? Looks like a very specific question for a patient.
Yeah. I mean, I don't know the additive value of MAB infusions. The difficulty of getting them, I don't think you can get it on Friday night or Saturday morning very easily. And they were tested as a sole agent. We don't have it on our protocol, not because we don't think it works. I'm a little bit underwhelmed with some of the data. I don't think it has as much data as ivermectin. So, I'm content with using our combination therapy protocol.
Got it.
Yeah.
Got it. This is an interesting question. Many people ask this. Is there any study or set of studies together with, let's say, ivermectin and vitamin D and mask and social distancing, which elevates the protection to the level of a vaccine?
So I believe if you look at the data from the prevention trials of healthcare workers, numerous trials from different areas of the world. So Argentina, a couple places, not just the Carvalho trial, right? There's the Chala trial in Tucumán that replicated Carvalho's findings. The Indian AAIMS in Delhi did theirs, did their prophylaxis of healthcare worker trials. You're finding equal and sometimes superior prevention against infection. So the answer is yes. There is non-vaccine prophylaxis treatment which are equal to superior to vaccines.
Makes sense. Mike Ridgway says, my CVS pharmacist refuses to fill on ivermectin script yesterday from Dr. Syed Heather. Could FLCCC perhaps create a listing of cooperative pharmacies?
Okay, so number one, it's not CVS policy. The pharmacist who tells you that is a liar. That's number one. That is not CVS policy. Number two, depending on the state you live in, pharmacists are not allowed to refuse to fill a prescription unless there's clearly a dangerous or mistaken dose or drug interaction. There are some states where pharmacists actually have the authority to refuse to fill anything. Texas is one of them. If you're not in one of those states, what this person is describing is that that's a pharmacist practicing medicine. And these pharmacists, listen, I'm not putting down pharmacists. I'm putting down these kind of pharmacists. They are a little bit too big for their britches. They want to start dictating what a physician can or can't do for their patient. So what I would tell this person to do is you call Syed. And if you called me and I'd done restriction, believe me, there'd be a pharmacist getting an earful. And one of the things I would tell that pharmacist is I'm reporting you to the state pharmacy board for practicing medicine. Practicing medicine. They cannot get in between a physician and their patient. They're literally putting someone's life at stake there. That's insane.
Thank you. Very important question and good answer. Boomer Gaming says, if a person after vaccine do not have antibodies, what does that means he never defeated vaccine and will be creating spike proteins forever?
I mean, if you don't have antibodies, either you can't produce them, like in some of the immunosuppressed patients who get it, or I don't know why you wouldn't. That's the only reason why you wouldn't have antibodies. I don't know. Maybe it was a faulty batch of a vaccine. I can't really opine or surmise anything beyond that. But we do know, right, that in the immunosuppressed, immunocompromised population, some of them are just not generating the antibodies. But outside of that, I don't know.
And it is possible that innate arm has taken care of a bunch of it. It is also possible that T helper 1 arm going to cytotoxic site, that may have taken care of it. And at the end of the day, as Dr. Kory said, we actually don't know what went on.
Yeah.
Colin Hamill says, does the Red Cross use ivermectin?
As far as I know, absolutely not. I mean, the WHO seems to rule the roost here, and it's just, that's going to be the historical crime. King Bean, is that when history's written, this is going to be another chapter where the WHO failed. You know, we're literally all the media across the world, right? So when you look at what's called the Trusted News Initiative, spearheaded by the British Broadcasting Corporation, which brought together Reuters, Associated Press, Agence France Presse, the three largest global news organizations, along with New York Times, Washington Post, and they all decided to not allow what they called medical information, misinformation. They defined it as stuff not approved by the WHO. So they gave the only megaphone for the world to a captured agency. Literally, that is the historical crime. They gave the only megaphone to a captured agency. The advice that we're getting from these public health agencies are so conflicted and so flawed. And that's the major. Don't get me started on this, because I think we were having a happy time. Now I'm going to go crazy again, but I do have to call it out for that. So yeah.
So one last question from me, and I know that we are at time as well. What is next for you in terms of your own career, in terms of FLCCC, in terms of this branding that you have, this advisory that you've been doing, advocacy that you've been doing? You are a name that is, I think, almost now known world over, at least in the medical fields. How do you build on it? What is next?
So we have another disease in which we have developed a highly effective protocol, and that disease is bacterial sepsis. We are going to tackle that next, and we hope to capitalize on our recognition to bring forth just a profoundly effective protocol for sepsis. And we have more research to come out to support it, and we hope to transform the treatment of sepsis worldwide. No small feat.
Awesome.
Yep.
No small feat. Absolutely. And if there is something done for sepsis, that would be such a great contribution to medical community and to the patients. Thank you very much for being here today. Thank you very much for answering your questions. And thank you very much for letting us ask you personal questions as well.
That was fun. Definitely a good time. I appreciate coming on. And all right, cool beans. Stay cool and stay beans.
Perfect.
All right.
You stay coffee and beans.
Yeah, exactly.
Bye-bye for now.
All right. See you, man.